your intervention is going to save the patient. With this, we move on to next concept, that is the fluid management in COVID-19. So when it comes to fluid, in general, we need to understand as a clinician, we are interested. So what is the impact of any fluid type on the mortality, morbidity, renal injury, effect on the coagulation, accumulated fluid balance, and so how much amount of fluid needed to for primary resuscitation. So do you have any so-called ideal resuscitation fluid which gives a predictable and sustainable increase in intravascular volume, so completely metabolized and excreted, so chemical composition is as close to as extracellular fluid, no adverse effects, cost effective? Currently it's very difficult to answer this question, but we'll see what we already know about fluid therapy in general. So already we know that lots of things happen, colloid versus crystalloid. We have a major trials like chest, Christmas, crystal. Success trial is the landmark trial, clearly which showed so starch like colloids are bad in terms of increasing so renal injury and requirement of renal replacement therapy in critically ill patient. Again, other colloid albumin. So in the safe trial, in some patients with a severe sepsis, so you can use 5% albumin, so with a marginal improvement in the mortality. But in the main analysis, which doesn't shows any major benefit, the to 5% albumin. Again, the data on the gelatin. So we don't have head-to-head major comparison, but we have some meta-analysis. Till we get major data, it is okay to go ahead with the gelatin, but there is a probability patient might have some anaphylactic reaction in the. Now I am going to narrow down my discussion. So among the crystalloid, we learned, so crystalloid are the option. So among the crystalloids, which one to choose even in COVID-19 patients? Okay. So when it comes to among the crystalloids, majorly normal saline versus the balanced crystalloids, that is ringer lactate, plasmolate, which are currently available. So if you go for physiological rationale, 0.9% saline, which is having a strong ion difference of 0 because 154 sodium, 154 chloride. So chloride is the culprit here. So chloride is going to cause renal vasoconstriction, which also hamper the renal autoregulation, which decreases the GFR and increases the renal injury and requirement of the renal replacement therapy. This is the physiological rationale. So these are the composition. If you see, so ringer lactate, the sodium load and the chloride load is bit acceptable. In the plasma light, so it is almost equivalent to that of the serum when it comes to sodium and chloride with add-on electrolytes also. So again, so this is the initial study which came across with a balanced V1 balanced solution. In surgical patient, what they have done, they try to understand the chloride load and the acidosis. If you see, immediately after surgery and within 5 hours, there was a significant increase in the chloride load. In the same time, there are more and more base excess also was more towards the negativity. So obviously, so chloride is bad when it comes to renal injury and the metabolic acidosis because it can cause normal anion gap metabolic acidosis. So till now, whatever the studies they conducted, what they have done, so in scenario A, so if they've done a randomized controlled trial, so at some particular chloride level, what they have done, so if the chloride reached 108 or more than that, stop that like continuing normal saline, shift the patient from normal saline to balanced crystalline. So then we are not able to understand what is the difference in outcome. So there are some trial in scenario B, they still continued like giving the normal saline even after chloride level which was not physiological, which is more than 106, 108. Then we got good outcome analysis data. One data interestingly which got published in relation to chloride liberal versus chloride restrictive strategy, that was in JAMA in 2012. So what they have done, so in Australian group, they have done the study. So they categorized chloride rich and chloride restricted fluid, including the ringer lactate and plasma light. So the impact they studied on serum creatinine, renal injury, and the renal failure, and the need of renal replacement therapy. All these three are significantly had a difference between chloride liberal and chloride restricted fluid therapy. So even though there was no difference in hospital mortality or ICU length of stay, but definitely so-called major adverse kidney injury events were more in liberal chloride fluid approach. Again, one important landmark trial we got, so that is called SMART trial, which got published in recently in 2018 in NEJM. So very good trial, which included near about 15,000 patients across 5 ICUs in USA. What they have done, so they try to understand like major adverse kidney events within 30 days. So there was a statistically increased so kidney injury events in patients, those who received normal saline, those who are critically ill. So in on the other hand, so there was no much difference in outcome, but there was a trend towards increased mortality in patients who received normal saline as compared to balanced crystalloids. Again, one more data. So this is in surgical patient, that is called split trial. So this trial, there was no difference in like incidence of acute kidney injury, need of renal replacement therapy, and mortality also. But the problem was most of the patients were like clear-cut elective surgery patient. They were not critically ill. Even in these patients also, they like taken into crossover when they reached a particular chloride level. And all these patients, they received normal saline less than 1.5 to 2 liter. So if the question comes, when you give normal saline as a continuous like maintenance fluid more than 2 liter, so then this load of like hyperchloremic acidosis is going to have an impact on the kidney injury. So this is one more trial. What they have done, single center trial, SALT ED here. So little patients in the early period in the emergency room, they try to understand balanced crystalloids versus saline. So there was an impact on the acute kidney injury, but there was no difference in terms of like hospital free days between the normal saline and that of the balanced crystalloid. But here you need to understand, maybe if a patient is in the ER, how much fluid he might receive, maybe in and around 2 to 2.5 liters. So here understanding is giving 500 ml of normal saline or maybe up to 800 to 1 liter of normal saline may not have any bad impact. But the question is, if you continue normal saline as a continuous maintenance fluid, so then it may have a bad impact on the kidney injury. So I told we are revolving around acute kidney injury, like chloride impact, normal saline impact on the AK. So is there any like evidence that AK is going to happen in COVID-19? So it can happen. The reason is multifactorial. It may be because of the cytokine storm or because of the organ crosstalk. I told patient can have myocarditis with the cardiomyopathy. They can have cardiorenal syndrome also. Many studies suggested they can have rhabdomyolysis with pigment nephropathy and acute kidney injury. No doubt, COVID-19 patients are more susceptible for acute kidney injury also. Even if the patients were already having a elevated baseline creatinine, so in them there was a poor outcome also. So then, what is the overall incidence? Current evidence suggests it may vary from 0.5 to 29%. So we have a bit good amount of patients who had AK in COVID-19 also. So it is more common in ICU setting as compared to simple ward admission. If the patients are going to have some comorbidities, there is a high incidence of COVID-19 induced AK. So definitely when we select like fluid, even in COVID-19, which is having an impact on the acute kidney injury, we need to select a fluid which is organ friendly, which are balanced crystalline. Among the balanced crystalloid, so we have a good comparison between ringer lactate and plasmolite, which is ringer acetate with the gluconate. So you need to understand. So there is some bit difference in the metabolism of lactate and acetate and gluconate. So acetate can metabolize it without liver in the peripheral tissue and muscle also. Amount of oxygen which acetate consume for the metabolism is less as compared to lactate. Lactate may not cause any lactic acidosis in mild to moderate liver dysfunction, but if the patient is having a severe liver dysfunction, which can have a problem in terms of lactic acidosis also, but not routinely. This is a basic difference between acetate gluconate and the lactate oriented fluids. So again, when it comes to nutshell on the fluid management, so initial resuscitation, so then after that we have to continue the maintenance fluid with the repeated assessment. Is my patient require further fluid or not? When it comes to after achieving your adequate resuscitation and all, then the era called de-resuscitation we have to consider. So each moment, so you have to consider what type of fluid, how much volume you need to give, so how much duration over which you need to give that volume, what are your targets you want to achieve, what are your safety limits. Target means you might target like urine output, lactate clearance, like peripheries, like peripheral temperature, or your safety limits like CVP, extravascular lung water index, are the requirement of oxygen. So you need to understand, answer all these questions when you consider fluid challenge or fluid therapy in any patient with a COVID-19. So what is the advice or the guidelines is suggesting? Even WHO is having a guideline. So option is isoosmotic crystalloid as a first option. Don't use hypotonic crystalloids or colloids like starches and gelatins. Albumin is having a very minimal, low quality evidence. When the patient is still requiring some sort of still hypotensive even after fluid bolus and all, consider vasoactivation, that is the norepinephrine. Target MAP of more than 65. Initial resuscitation. So with sepsis background, you need to give 30 ml per kg. Even survival sepsis guidelines also in COVID-19, we got an interim guidelines from the survival sepsis committee that also given fluid type is crystalloid. So fluid response, use some dynamic indices. Fluid volume initially 30 ml per kg. When it comes to vasopressor, norepinephrine is the first option. So with this, so what we can conclude, so in case of obvious shock, don't do fluid responsive test. So you need to understand if the patient is obviously in shock, like hypovolemic, maybe because of like loose motion or early phase of sepsis, don't consider doing any fluid challenge test in them. Give them a resuscitation fluid, that is 30 ml per kg. So administering fluid or not can be asked only if cardiac output is to be increased or not. Because see, we can improve the perfusion pressure in two ways, either by giving the volume or by constricting the peripheral vasculature. You need to understand whether you are going to improve the perfusion pressure by giving the cardiac output, by increasing the cardiac output by giving fluid, or by constricting the vessel. So decision of fluid administration should not be based solely on presence of preload responsiveness, because there should be presence of hypoperfusion is mandatory. I told healthy heart is fluid responsive. Patient should manifest signs and symptoms of hypoperfusion like elevated lactate, decreased urine output, altered sensorium, cold peripheries, postural hypotension, increased base excess, so and so. Then only we need to give the fluid. So again, while giving the fluid bolus or the resuscitation, you have to understand, are we crossing our safety limits also? So testing for fluid responsiveness not only help to decide on administering fluid, we need to understand when to stop the fluid or when not to give the fluid at all. And we can use the fluid responsiveness test for de-escalation phase of shock management also. We know that there is something called SOSD management of shock: salvage, optimization, stabilization, and the last phase is de-escalation, that includes de-resuscitation, diuresis also. During that time also we can use fluid responsiveness test also. So considerable number of COVID-19 patients have shock. So conservative fluid strategy, this is only after adequate initial resuscitation. So we can use advanced hemodynamic monitoring, which tells about cardiac output when the shock pathophysiology is complex. Fluid overload in such patients is an independent predictor of mortality. So colloids have a limited role. Again, balanced salt solutions are the crystalloids of option. So lactate based solution, still we are okay, but in a patient who is having a severe liver dysfunction with the background of COVID-19, we should be bit judicious on using lactate based balanced salt solution. With this, I'll conclude. Any questions are welcome.
Thank you so much, Dr. Harish. I think that was really enlightening and a wonderful presentation. Thank you so much for taking the time out for this topic today. A very pertinent and very important topic, especially considering the whole COVID-19 situation. So there are a few questions that are posted in the chatter. One is that now that the evidence suggests that EGDT or early goal-directed therapy has no effect on the mortality, how do we assess the daily fluid requirement? So I know you alluded towards it greatly towards your talk, but if you can just briefly, tell the audience what are the daily requirements that you need to check.
Basically, maybe 2 decades back when Rivers introduced this so-called EGDT, early goal-directed therapy, so he was having a very fantastic theoretical rationale. Means like someone who is having a low CVP, So target particular CVP of 8 to 12. So give them blood to keep the hematocrit of around more than 30-35%. So if the contractility is poor or if they still having hypoperfusion, give them the dobutamine. So give them like norepinephrine to increase the mean arterial pressure. Like you need to understand, so there is no need to attach particular value and you start resuscitation, because if you consider giving blood for improving the hematocrit of more than 30-35% will have more and more adverse effect because of the blood. So after that EGDT we got process promise arise trial which clearly told that no need to adhere to specific targets. Okay, but whatever we are doing standard care means like you measure the lactate, initially give some fluid of 30 ml per kg to assure at least a patient is going to require means receive that much volume, and remeasure the lactate. When it comes like you are dealing with some complexity, use some dynamic indices like pulse pressure variability, SVV and all, because we need to understand CVP, so SCO2, all those things are having their own limitation. Because if you consider this so-called central venous oxygen saturation, it is like global indication of our perfusion state, which is having its own limitation. So currently we are moving away from CVP, SCO2 and targeting a particular hematocrit and particular CVP more towards the dynamic indices. Practically, what you can do is you assess if you feel patient is in shock, his lactate is elevated initially, give them adequate at least 30 ml per kg of the fluid initially. After that is the question. So, is my patient require some sort of ongoing like fluid, recurrent fluid challenge and all? So, most commonly, most easy approach at the bedside, you can use echocardiography. Do your IVC assessment, but don't think single value of IVC is going to be helpful, because single value of IVC is as equivalent to that of your CVP. So you need to understand. So repeatedly you see the IVC variability, collapsibility or distensibility index. You see your lactate like peripheries temperature. So then you give some fluid. So again you can work with echocardiography, some indices like velocity time integral. You see this patient is having some pulmonary congestion with the B lines, with the putting echo probe on the lung field. So again, if you are not crossing the safety limit, you can continue, reassess, give fluid, reassess kind of this one. This is one easiest method if you don't have any advanced hemodynamic monitoring.
Thank you, Dr. Harish. I think there's one more related question is regarding the use of, one size fits all in the surviving sepsis guidelines, which suggests that use of 30 milliliters per kg of fluids is good for any septic patients, and that is being extrapolated also to COVID-19 patients. So what's your opinion on that? Does one size really fit all?
So you need to understand. So when they given some sort of in between guidelines from the survey sepsis guidelines for COVID-19, their thought process was like a patient with a COVID-19 with a sepsis kind of this one, because your question is very clear. And see, this 30 ml per kg initially, all the patients with COVID-19 may not require at all. Okay, if they are perfusing well, so you are the clinician at the bedside. So this so-called 30 ml per kg fits into all the patient is not acceptable. If you feel patient is adequately perfused, so it's conscious oriented, so his lactates are fine, good urine output, warm periphery, no need of fluid at all. So then why they made this 30 ml per kg? If the patient is manifesting with the background of sepsis, so then
Called
maybe
me, baby.
at least this 30 ml, at least on a mandatory basis they will receive. That was the concept. It is, see, some patient who is in shock might require more than 30 ml also. Some patient who are having a minimal some sort of relative hypovolemia, they might require less than 30 ml also. But to make sure they made this 30 ml number, but it is your responsibility, our responsibility to individualize the therapy at the bedside.
Thank you, Dr. Harish. I think the final question, because we are also running out of time, is extrapolation of the SMART trial. What is your opinion on that? It also had critically ill patients in COVID-19. Those who are admitted to the ICU are also critically ill. So, what is your opinion on the SMART trial extrapolation into COVID-19?
Here, more than extrapolation, so this we recurrently and repeatedly proved normal saline is no more normal, because the worry is about the chloride load. So whether patient is critically ill, surgical, septic, trauma patients, even other than head injury. In polytrauma patients also, we have lots of data on normal saline, which causes hyperchloremic acidosis. Again, that chloride is the culprit. So even in general pool of patient, we forget about critically ill or COVID-19 patients. So I think it's fair enough to accept that data. So it is good to like continue chloride restricted strategy when it comes to maintenance fluid. I told, so if you want to give in the ER, maybe 500 ml bolus of normal saline, it's fair enough. No worry on that. If you want to give maybe another 300 ml, it's good. But when it comes to continuing like 100 ml per hour of maintenance of fluid, at the end of the day, your burden of chloride is going to be very high, which leads to so very bad like normal anion gap metabolic acidosis with the impact on kidney injury. So that is fair enough. We can extrapolate the smart result in any particular group of patients.
I think due to paucity of time, we will conclude the session here. But then, thank you so much for your very enlightening lecture and taking us through this very pertinent topic in this whole COVID-19 situation. Thank you again. Thank you. Thank you all participants for an interactive session. Thank you so much for all for joining us. Thank you.
Thanks, Gaurav and Baxter. Thanks.